Good afternoon, everybody, and welcome to Care Connection, the free live webinar, the second Thursday of every month, and we do also have special edition Care Connection webinars. Today we have a very special guest speaker. Her name is Dr. Angela Allen. Before we begin, I just want to let everyone know that today's presentation is going to be in listen-only mode. At the end of the presentation, you could type in your questions on the right-hand side of your control panel. In addition, with that same control panel on the right-hand side, you will find today's PowerPoint in PDF under Handouts. Dr. Angela Allen, her topic today is going to be what every caregiver needs to know when hospitalization happens. She has a Doctor of Philosophy from Arizona State University, College of Nursing and Healthcare Innovation. She's also a certified rehabilitation registered nurse with a specialization in research. Dr. Allen was appointed to serve as a research nurse at Banner Alzheimer's Institute. Banner Alzheimer's Institute's vision is to be the prominent interdisciplinary research institute devoted to world-class basic and transitional research, clinical care, prevention, and education. We are so very happy to have you today and for you volunteering your time today. Please begin today's presentation.
Thank you. Today I will be talking about what every caregiver needs to know when hospitalization happens. So before we begin, I'd like to share several statistics with you. Many of you all may be familiar with these statistics, but just to enlighten you on the disease and also how it has impacted our society. About 5.8 million Americans are currently affected by Alzheimer's disease or related dementia. It is expected by 2050, 14 million Americans may be affected. The average life expectancy following the diagnosis is about 8 to 10 years, and I will go into detail as it relates to these years later. Dementia has become the 6th leading cause of death among older Americans. Just keep in mind that just last year, this was the 5th leading cause of death. So in research and also in treatment, we have made some waves. How does it affect us socially? Socially, the social impact of Alzheimer's disease and related dementia impacts us because 7 out of 10 persons, that's 70% of these people who have some form of dementia live in their home, so pretty much in the community. Approximately 44 million family and friends provide about 83% of their care at home. These are unpaid caregivers. 80% of these caregivers suffer from high levels of stress, and this has been proven by research studies, lit reviews, as well as instruments that have been used, such as the Zarit Burden scale, etc. 50% of the caregivers suffer from some form of depression, and this right here is the most surprising percentage. 40% of caregivers often die first if they provide care for their loved ones without assistance, that's without community resources, family support, if they're caring for their loved ones greater than 8 to 10 years. So basically that's the span of the person who has some form of dementia. How does this impact us clinically? Clinically, these numbers may be surprising as well. Anyone who has some type of cognitive impairment in a clinical setting has been identified that 25 to 40% of these persons have some type of cognitive impairment in the clinical setting. I may add that these numbers may be inaccurate because several of our patients, as you know, have not been diagnosed at all or misdiagnosed with some type of other psychological diagnoses. 60 to 80% of these cases are unrecognized in the clinical setting. 32 to 82% have behavioral symptoms, and many of you all may recognize this when they're placed on behavioral units. 49% of the patients who have some form of dementia have been admitted into an emergency room, and this is actually 49% per year. But what's more interesting is that their caregivers, about half, 21%, have also been admitted into an emergency room per year, and this is again an average per year. 26% have been hospitalized, and 11% of their caregivers have been hospitalized. Now, we all know in acute care setting that the average length of stay of a person in an acute care setting, that's usually when a person goes from the emergency room and then right on a unit to actually manage their care, is about 2 to 3 days. For a person who has some form of Alzheimer's disease or related dementia, their length of stay is 6 to 9 days. And so, as you know, that is actually an increase in not only cost, but also an increase in debilitation of that particular person. What is dementia? And that's the surprising question. Dementia, many people have thought as a disease, and it isn't. It is actually a syndromal statement. This statement or term is characterized by several items, and these items are as a result of the impairment are memory, language, personality, behavior, and judgment. And we will talk about these shortly. Now, many people have asked, how many types of dementia are there? If we're looking at these 5 categories of memory, language, personality, behavior, and by the way, these categories, when we look at these different areas, we're not looking at them at the exact same time. These things can happen in stages, such as memory and language may happen in an early stage, and then gradually as the disease progresses, we may see some issues with personality, behavior, and then of course, eventually judgment. But if we are actually defining a person with some form of dementia, it is a progression of these categories, and the progression usually occurs greater than 2 to 3 weeks. So based on this definition, again, how many forms of dementia are there? Well, there are over 100 different types of dementia based on that definition of, as I've mentioned, the syndromal statements. I'm going to highlight 4 types of dementia, and these 4 types of dementia, many of you all may be familiar with, particularly the Alzheimer's disease. The first thing I like to talk about is Lewy body dementia. Lewy body dementia is basically a dementia that is actually, it mimics a little bit of Alzheimer's, where you have some cognitive debilitation, and then also Parkinson's, where you see that shuffling or that pill rolling or that slow walking movement. Lewy body is actually a disease that has been undiagnosed because many people have actually just been stamped with Alzheimer's or stamped with the disease of Parkinson's. But technically, when you have a neurologist or a psychiatrist who specializes in dementia, they'll pick up particularly on those 2 areas, again, the cognitive impairment, the physical impairment, a little bit of each, but not actually having either, and then recognizing it as a disease such as Lewy body. Just to give a little bit of history of Lewy body is actually a scientist, and he was a protege of Alzheimer's. So he pretty much picked up, again, a lot of the information that Dr. Alzheimer's had recognized in patients, but also looked at the physical inabilities of those patients. The next one I'd like to talk a little bit about is frontotemporal dementia. Now, frontotemporal dementia is exactly what it says. It's the location of where the dementia occurs, in the frontal and also temporal sides. Now, frontotemporal dementia pretty much impacts a person at a younger age. This is when you may see people who've been diagnosed, we call them early onset, at 50s, 40 years of age. And also these people pretty much act out. You'll see them a little bit more combative, frustrated, irritated, aggressive. These patients also basically are impacted by that frontotemporal area. So it affects their logical thinking, if you will. And so that's why you may see a little bit more concern in this area. Now, this is not, again, just frontotemporal. All of the diseases that I'm talking about can actually affect the individual in the same way, but particularly frontal temporal dementia have those characteristics. The third one, vascular dementia. Vascular dementia is usually occurs right after a stroke. This is probably the most misdiagnosed or underdiagnosed dementia. With vascular dementia, a person have had a stroke, and because of the residual of the stroke, the person, again, remember those characteristics, having problems with memory, language, ability to their behavior. You'll see those characteristics directly after the stroke. A lot of neurologists miss this because they're so focused on the stroke or the TIA, and they're not focused primarily on what the person has lost in the long term or the progression of. And again, this is where we see the vascular dementia. Now, all three of those dementias that I just mentioned, about less than 20% of patients who have been diagnosed will probably have one of those dementias. Here we see the most common type of dementia, and you hear this one more often than the others, is basically Alzheimer's disease. 60 to 80% of persons who have some form of dementia are usually recognized through the diagnosis of Alzheimer's disease. And oftentimes you will hear the providers, if they diagnose a particular person in the early onset, they may call mild cognitive impairment or memory loss or forgetfulness. And then eventually, as the particular person develops certain characteristics, then they will begin to actually see or diagnose them with Alzheimer's disease. And this isn't so good because each of these diseases that I've mentioned have different ways of treatment, non-pharmacologically as well as pharmacologically. And when I say pharmacologically, I'm referring to medications. So it's important that the primary care provider actually have the patient be assessed formally by a neurologist so that they can determine what type of treatment is required for this individual. Now, we talked about, again, the different types of dementia. The next thing I'd like to talk about are basically the stages of dementia. Now, as mentioned earlier, dementia is a progressive disease. It also is infected by the brain, so we will see the progression. There isn't oftentimes people will say the individual is getting better. That getting better could occur based on the behavior that you've, obviously have shared or imposed with that individual. It could be medication. So it could be the environment. It could be various areas in which this individual's behavior has improved, but it is not due to the disease because, again, this disease does progress. So typically this disease upon diagnosis lasts about 7 to 10 years. Each stage is identified through early, and sometimes you hear them called mild, middle or moderate, late or advanced. And each of these stages require different services and strategies along the way. So you may have an individual that may have frontal temporal dementia in the early stage, or you may have a person who has Alzheimer's disease and they're in the early stage and the moderate stage. So you're looking at the type of the disease as well as the stage of the disease when you are working with these individuals. Let's talk a little bit about the early stage. In the early stage, here's some of the things you would see. Short-term memory loss. And when I refer to short-term memory loss, and again, if you're jotting this down, you'll see that short-term memory loss will basically be an individual who's lost their memory from 1 day to 7 to 8 years. And that's that short term, whereas let's say an individual who has retired 5 years ago, if they've lost from 1 day to 7 years, and they're often saying, I want to go to work or I want to go home, that going to work could be the fact that they're reflecting on 7 years ago that they were working. So that's a short term when we're referring to that. And in this early stage, this is where you'll see that 1 day, meaning they may have lost yesterday, to 7 years. Executive functioning, these are things that they are thinking logically, things that they have done like writing a check or perhaps organizing their day. These are things that they're unable to do. And if they are, they're missing pieces or what they're supposed to do. And when we're looking at step-by-step processes, I'll give you an example with the check. They may write a check and put an extra zero, which isn't good, or they may write a check and not sign it. So these are, again, thinking of the step-by-step areas in which they are, obviously supposed to do, and they're not able to at this point. Oftentimes we miss this because, again, A, it's early stage, and B, we write it off as they're just getting older or they're forgetting, so not a problem. But when it happens consistently, then we know that there's a major issue. Problems with language. Problems with language could be the fact that they're repeating themselves. And again, this is early stage, and oftentimes we miss this as well, because what they would do is they would actually say something, and then they would say, wait a minute, such as like, are we going to the store? And your response could be, yes, as I've mentioned earlier, we're going to the store. And then later they'll ask you again, well, where are we going, or are we going to the store? Most of the time people will brush this off as, oh, they're just getting older, or maybe they're not able to hear me, or perhaps I didn't say it loud enough, or maybe they're overwhelmed with certain things that's going on in their life. This is where you actually, again, you have that aha moment and say, wait a minute, there's a major concern here. Disorientation to time, and many times we've seen this. A disorientation to time could be the time of day. I'll give you a perfect example. I'm in an area where I'm 3 hours different. I may reflect as a person who has an early stage and think of myself being at a 1 o'clock time or a 2 o'clock time as opposed to a 10 o'clock time. So I'm not able to adjust to that time. Also, the time of day. I could think that today it's sunny outside, so it's morning, where it could be evening. Again, I'm not focused on specifically a PM or an AM. I'm focused primarily on what I see. And then emotions. Emotions usually occur because they know, the individual who has some form of dementia knows that there is something going wrong. They've made too many mistakes, and so they're uncomfortable with the individuals that are around them that have either corrected them or that they have actually not able to adjust to the environment because of those things. And so again, their emotions are impacted by this. If you notice on the screen, the brain, that you'll see on the brain, it actually shows you where this Alzheimer's disease and related dementias, it affects the brain area. It usually occurs right in the center. We call it the hippocampus. And gradually, as the stages increase, when we get to the middle, you'll see the blue area will obviously grow because it's impacting various areas of the brain. And here that is right here. So the next one is memory. We're still having that effective memory. As I've mentioned, that 1 day to 7 years, they're lost. In the middle stage, we're going to add an additional 10 to maybe 20 years. Because in the middle stage, we often call that the critical stage, where we truly see where this individual have major problems. So in this stage, this individual may have lost, like I said, from that 8 years to 20 years, where they have lost almost 20 years of their life cognitively. So they're not only unable to see or understand what's going on today, but it has taken them back all the way to a point in their life when they were, again, if they retired at 65, 70, in their prime at 45 or so, this is how they're thinking. Communication, again, is affected by this. The communication, they're unable to understand as well as communicate information to you. So they're repeating. They're asking you, basically looking at you to repeat things. You have to break things down simpler and not have full sentences, but perhaps even just words or statements. We call it keep it simple. Senses, they are not able to pretty much grasp. Their hearing is not a problem unless there's hearing issues prior to physical issues as relates to hearing, but they're not able to taste as well. They're not able to feel as well. And also visual becomes an issue also. Impaired judgment and problem solving increased. Again, this is not where you're asking them to plan a trip. You're not asking them to travel certain areas that they're not used to traveling. Shopping in the grocery store, it's their judgment and problem solving has truly been thrown off at this area. And again, this could be not so much at the beginning of this stage, but towards the end. Changes in personality behavior increase because now they recognize that there is a concern with their understanding. And also now they're acting on it. And here's where you will see the wanderers. We call them those who silver alerts, where they're now wandering and trying to figure out or trying to go back to where they think they have come from, such as I want to go home, or like I want to go, to work, as mentioned earlier. And then they're more dependent on self-care. This is where, unfortunately, dressing their basic ADLs is going to be thrown off. So here they're depending on that person who's caring for them, their primary caregiver, to prepare their clothing. They're not going to say it, but they are requiring some assistance in that area. Bathing, dressing, they may even miss brushing their teeth because that is not, again, a logistical task for them when they consider that as a day-to-day activity, or we do and they do not. In the late stage, and we call this the very severe stage, the advanced stage, as mentioned earlier, this is where they would lose, in addition to those 7 years, and as I mentioned, 8 to 20 years, we're going to now add on 30, 40, 50 years. So that 75-year-old can be now 25 years cognitively, or maybe even younger based on the severity of this stage. So their memory loss, we call it long-term memory loss. They've lost more than just that yesterday, but they've lost pretty much almost their whole older age, middle age, and now they're into their adolescent and again progressing to their younger age. Communication is thrown off, and the communication could just be nonverbal, whereas we're recognizing that the individual is receptive to a smile or a touch and not so much of a long conversation. Even reminiscing doesn't affect this individual anymore because they can't really recall as much as they have. So you sharing information with them about do you remember, and no pun intended, but that's not something that's going to be helpful. They may even make up some things just to carry a conversation if they're able to. And this is when, of course, you're going to recognize that and make some adjustments. They're only oriented to self. So again, looking at the brain and the picture, you'll see all of the blue areas affected and the memory is pretty much gone. So they may not recognize you as a primary caregiver, as a loved one, as a spouse, as a child or daughter, son, or grandchild anymore. Here is where they may recognize more so just themselves and the fact that they're doing the best they can by recognizing themselves. The medications I'll go over briefly. We call them our top 5. As you can see, there are 4, and I'll talk a little bit about the last one. On the early stage, Aricept, Exelon, and Razidine are our top 3, and that is usually offered during the early stage. The medications, the Aricept and Razidine, are pill form. One is an extended release, and one is an immediate release. The Exelon is a patch. We encourage our primary care providers to actually subscribe this to individuals, even if they are in the MCI, we call mild cognitive impairment or the early stage, because again, what this medication does is, and it has proven to do, and these are FDA approved, is slow down the progression of the disease. It's not going to stop it, it's not going to reverse it, but it'll slow down from those stages. So as mentioned earlier, we said 7 to 10 years that the disease lasts, and this again is based on the individual. Well, it may last 10, 12, 13, or 14 years with these medications. We want to continue the chronic condition medication. So if there's a diabetic or hypertensive patient, continue to take those meds. But keep in mind, you're getting ready to start some antipsychotic medications, particularly depression, because this person has been hit really hard on and been informed that they've had some type of cognitive impairment. So we want to make sure that this individual is being treated for that. In the middle stage, we have what is called Namenda. And Namenda is actually a medication that's given to slow down the progression of the disease as well. But with Namenda, what we do, and we've added this, by the way, you can continue Aricept, add on Namenda. What Namenda does is the glucose level in the brain has begun to dissipate, remove, go away from the brain, if you will. With Namenda, it allows the glucose to remain in the brain so that the person can have enough energy and also have thought process so that they can function better. So Namenda does pretty much allow the Aricept to work just as well, but also increase the thinking of and I shouldn't say increase, but maintain the thinking of that individual. We want to continue chronic medications, but remember in the middle stage, I shared with you that this is when they're acting out, their behavior is going to change. So we want to make sure that we are addressing those behavior concerns, emotions, personality with mood and behavior medication. So again, you'll see medications being added to that person's regimen of antidepressants and chronic medications, chronic condition medications as well. In the late stage, we're going to continue our Aricept, we're going to continue our Namenda, and as I've mentioned, there are 5 medications. There are 3 that I shared in the early stage, the one that I just shared now, and then the third one is Nimzuric, which is actually a medication, a combination of Aricept and Namenda. This is when an individual chooses not to take pills, and as you know, with a cognitive impaired person, they may not want to take medications orally. So, or 2 or 3 pills orally. So here's when you combine the Aricept and Namenda together, and you prescribe or give Nimzuric. One thing about Nimzuric is FDA approved, but it may not be covered by insurance because the other 2 meds are already been given. In the late stage, again, we continue the medications, but we want to also provide medications for mood, pain, and comfort. These medications, I would encourage you not to give as needed, because oftentimes the individual may not be able to share with that they need it, such as, I'm in pain, what's the scale of the pain, that is needed. They may actually not say anything, or they may act out, and we don't know what the acting out is due to. Is it due to pain? Is it because they are frustrated? Is it because of the disease? So we want to provide scheduled pain medication. Typically, like we provide Tylenol, maybe 325 milligrams of Tylenol in the morning and then 325 in the afternoon, just so that this person can actually reduce any uncomfortable feelings, if you will, physical ailments, if you will, because remember, they still have physical ailments around this time. And then, of course, we eventually address the hospice care, and hospice is usually provided to the individual in the late or advanced stage, pretty much towards the last 6 months of their life. And we are very familiar with that in any of the diseases. We recognize that. So we're here to talk about, what do you need to know when persons with Alzheimer's disease or related dementia happens? Well, I like to start off with, here we have this individual, and you've seen the slide where they talked about the percentage of patients who have been hospitalized to the emergency room, the length of time of being in the hospital. And then, of course, we're trying to prevent for, the caregivers going in the hospital. So just like in any situation, you want to be prepared. So my recommendation would be to have a pre-packed package, if you will. Because again, we do not know when these incidents will occur. Have your health insurance cards handy. I would highly recommend that you take your cards, if you have them in your wallet, make a copy of them and put them in a folder, because again, when we're requesting that information, we don't necessarily have to have the actual card. We could actually have paper that is legible enough to read off the information on the card. Have the list of medications and any allergies this individual may have. Keep in mind, this individual may be hospitalized, or obviously they may go to the emergency room without you. You're traveling or you're away from the home. So all of this information is readily available. They may not be able to share it. Even an individual in the early stage may not be able to share all of their medications or allergies with the hospital because of, again, those periods of forgetfulness. Have your healthcare provider's name and number available. Copies of healthcare advance directives, medical power of attorney. In Arizona, we talk about mental power of attorney, fiduciary information. Have all of that available so that whomever and when that individual goes, this is something that decreases your stress level of providing it, but also allow the individual information to be accurate. Also, put on a sheet the preferred name and language that person you would like to be called. We know that in hospitals, people will say Mr. or Mrs. And keep in mind, if their person is in a moderate or late stage, they may not recognize the Mr. or Mrs. Jones, if you will. They may recognize their name being called by their first name. Because again, they're that quote unquote 20 or 25-year-old adolescent, especially when we're looking at the moderate to late stage. They're not thinking of themselves as this older adult. What are some of the keywords? I like to use the word keywords, triggers, things that will either allow the person to be in a positive mode or in a negative mode. Is this something they do not like to hear? Or is it something they like to hear? Please keep that in mind. And when you put down keywords, Write down whether it's a negative or a positive word that will trigger that individual. Glasses, dentures, hearing aids. Make sure you have all of those things and even type that information out. Check it off that these are things that that person have. And then, of course, where would those items be kept when that individual is no longer using them, whether it's something that they've used in a home or if they're in the emergency room, where are those items kept? And then also behavior concerns. Let the hospital know that my loved one wanders, or my loved one will try to, he was a mechanic back in the day, so he's going to try to obviously tamper with some of the gadgets that you guys have around here. Or he gets frustrated when he hears a loud noise. So make sure that they are aware. Trust me, and I say this because a lot of the healthcare providers are focused on why their work, their area of interest in the hospital, and not necessarily the area of that particular person's mental state. So you want to help that healthcare provider understand those things as it relates to your individual. What are some comfort objects? Some comfort objects. I remember a case where one of the ladies I worked with, she obviously held on to her rosary. And this was something that the hospital needed to remove because they were trying to obviously help her. She had a broken hip. If that comfort object was that important to her and it decreases her ability to be agitated, frustrated, and it decreases their ability to not medicate her because of the frustration, that's the most important piece there. It is not removing it so they can get to her to assist her with her hip. It's allowing her to keep it so that she can be comfortable at that time, so that they can provide better care and decrease that agitation or uncomfortable feeling for that individual. Now, what to say when you're in the hospital? Ask a friend or family to accompany you and the person who has some form of dementia. We call it persons with dementia. That can be overwhelming to you. So it could be some things that you may forget at the time. It can be the fact that while the individual's in the back, you and that person that you've asked to accompany you can conversate. You can decrease your stress level, can allow you to vent. Or you could share that time where you're in the back and perhaps in the waiting area, you rotate and sit with the individual who's in the room. You want to make sure that taking care of you is probably one of the most important pieces at this time, because when that person's done, they're done in the emergency room and hopefully return home. But if they have to go through the stages of the hospital, you are able to be able to care for that individual, and you're in your right mind and physically as well capable of doing so. Inform the staff that the person has dementia. Don't make the assumption. Remember, many patients are underdiagnosed, misdiagnosed. The information on dementia may not be the number one concern that they're looking at. So let the staff know, my loved one have dementia. And if you can, let them know what kind, educate them on that, and the stage that they're in as it relates to dementia. Be prepared to explain the symptoms leading up to the hospital visit. Keep in mind, they are going to go into that room, especially an emergency room, and they're going to talk to the patient. Inform them that you are the provider for that patient. You are their primary caregiver, and let them know that you must provide that information, because the individual may not be able to share the information, or more importantly, they may not share accurate information. Sometimes, and this is a true case, there was an individual who was in the emergency room and they shared that they had fallen and that their caregiver had pushed them down and caused their fall. Well, again, this is actually what they thought during the time of their fall. So they're sharing something that was inaccurate. Be prepared to not be on the defense, but explain to them why they said it and what happened. Because again, as you all know, if this is something that this individual says, the person with dementia says, it can lead to other situations such as adult protective services. So we want to try to alleviate that by explaining what went on during this situation. Ask questions if you don't know. Ask about their medication, their lab values. What procedures are they going to take? If they're inserting a catheter or IV, make sure that they are aware that this person has some form of dementia. Be prepared to recognize their behavior. And if I need to be in the room, meaning you as a caregiver, to hold their hand, explain that situation, allow me to do so. You want to prevent any type of antipsychiatric medications, that can obviously cause even more damage. You want to make sure that you're actually there to soothe that individual and also educate the staff. Ask a doctor if some procedures can be done during outpatient as opposed to during that overwhelming time of emergency room stay or inpatient stay. So again, this is allowing decreased activity as it relates to hospitalization for that individual and increased comfort and recovery for not only the individual, but respite for you. Ask friends and family to call and keep others informed. It decreases the ability of having multiple calls to you, also having multiple calls to your loved one. They may call the room and ask questions that individual may not be aware of or unable to answer. Keep the person with dementia informed, but when you do, keep it short and simple. You don't want to talk about you've had a broken hip, they did surgery, this is the medication you're on, you're in the rehab, you're going to be here for a long period of time. You want to remove that whole conversation with, you broke your hip, you're getting better, and I'm hoping that you'll be home soon. This is it. I will be here as often as possible to support you. And that is something that I would stress too. Try to be there, you or a friend, family, or neighbor, as often as possible to support them during their time of recovery. What do you want to do? Be patient, stay calm and positive. Your person with dementia can sense your ability of anxiety, stress, depression. And if you're that way, just imagine how they're going to be. So you want to obviously, again, spend as much time away from the environment as possible. But when you are there, you're going to have to change your behavior. You're going to have to be in a mode or a way where you can actually comfort the individual as well as communicate with the health professionals. Do not assume everyone knows your person has dementia. So keep in mind, earlier I said that you shared that with the emergency room staff, that the person has some form of dementia. Now you're moved to an acute care unit. So every time an individual comes in, there may be a way that you can communicate or something that you can share so that they would know that you are there to support, but yet so advocate for your individual. For instance, you may have an individual like a phlebotomist who would come in and draw blood. They'll see you sitting there, they'll walk right over, and they'll begin to talk to the individual, the patient. And while talking to the patient, they're ready to draw blood. Well, that can be a little anxious for not only you and also the person with dementia, but for anyone actually. So you want to be able to pull that individual aside, the phlebotomist, and you may want to share with them, my husband has dementia or my wife has dementia, and let me explain how we need to do this in order for you to get your job done and for my loved one to be able to, of course, get the services that they need. Build a team of support, formal and informal, during the hospital stay. Get to know the hospital staff's name. If you have a nurse or, of course, the doctor or regular staff such as dietary or housekeeping or whomever, get to know who they are, let them know who you are, and then allow them to befriend the person who's in the hospital, person with dementia in the hospital, because that'll make them more comfortable, them meaning the caregivers, the providers, the staff, and also the person with dementia. Have a family or friend stay with the person with dementia if you are not available. And this is something I shared earlier, because again, you may not be available at all times. There may be opportunities where you can actually, again, have respite. You may be asked by the case manager to go out and seek additional services. And you are unable to do that if you are always in the hospital setting or the rehab setting with your loved ones. So you want to actually have an opportunity for rotation. I can tell you out here, I've asked some of my family members, when you have loved ones that are flying in because, again, your loved one has basically, the person with dementia has basically fallen, broken their hips, so now the children are coming in. Allow that time for the children or the individuals to sit with that person with dementia in the hospital, while you are out taking care of business or taking care of yourself. Help the person fill out forms like the menu, or assist with ADLs or certain items in which they've been asked to complete while they're in the hospital. This is something that you want to be able to do and provide. Again, making yourself not necessarily you're not useful while there, but just being even useful and important when you're taking care of tasks that these individuals are unable to take care of. Cue the person to do as much as possible. This is very important. Even though there's a functional or physical functional inability for that individual, there isn't necessarily the cognitive inability as much as you think. So allow that person to do as much as possible. And even if they aren't doing it the way they're supposed to, applaud them. Say great job and know that they've done the best they could at that time. Give you a perfect example, brushing their teeth. If the individual is supposed to, obviously prepare for the day, and one of the tasks is brushing their teeth, you may set up the items around the sink, and this is again in the hospital, allow the person to put the toothpaste on the toothbrush and allow them to brush their teeth. Oftentimes we like to intervene because they've not gotten into, have not brushed the whole mouth or all of the teeth. So you want to let them know, good job, they've done the best they could at that time, and move on. Oftentimes persons with dementia get frustrated when you're correcting them because they feel as though they've not done the things that they're supposed to do according to what you expect them to do. And make sure they're always comfortable. This doesn't just mean physical comfort. This means also emotional comfort, because you want to let them know that you are there for them, and everyone in the hospital is also there for them so that they can get better and, of course, return home. Working with the staff, place a copy of the personal information sheet in the Persons with Dementia chart. In some cases, we're now looking at electronic medical records, so you may not be able to place the actual sheet in. They may scan it, they may overlook that information. So in some hospitals, and I believe in most, they have what we call cork boards or whiteboards. Here you can actually tape or put that information in some way through a magnet or whatever in regards of that person's personal information, that personal information sheet, somewhere where it's visible for individuals who are caring for the person with dementia, that they could see it and understand what this person needs or certain things that they have or require. I've often asked to give this information to the social worker, the case manager, because they're often the ones that's going to be requesting this information or delivering information for appropriate staff. Request limited staff. I cannot stress this enough. Request limited staff. Keep in mind, this person is already overwhelmed. Their environment has changed probably about 3 or 4 times. And I know you're probably thinking, well, how possibly 3 or 4 times? Well, you've gone from the home, if they've been picked up by the EMS, you're talking about an EMS, you're talking about an emergency room, then a hospital, from the hospital to a rehab, from a rehab to a skilled. So we've named basically, excuse me, several areas this person has actually changed. Not to mention tests. They've gone to X-ray, MRI, various scans. They've gone to different rooms in the facility. Perhaps if they're in the hospital, they've gone to the dining room to eat. So with all of the occupational and physical therapies room. So with all of these different areas, they've seen so many different people. So you've already overwhelmed them with a number of people that they've seen. Make sure the person is safe. Again, falls, wandering, and the hospital does a very good job with that, but you want to also assist them in that area. Plan early for discharge. This is when that loved one or the family members or friends are in the hospital overseeing or visiting that patient. This is when you're out there taking care of business so that you're better prepared. Realize the staff is doing the best they can, and that's based on how well you're teaching them and the information you're providing for them. Know the person may experience fatigue. Again, they're tired, change, too much demand, overwhelming stimuli, misleading stimuli, communication concerns, activity, as well as illness. In fatigue, they have basically problems with more energy for the same task. And this is their problem. They need more energy for the same task. I often think of what Alzheimer's disease does. It actually impacts, remember that blue area is shaded? So it's causing that person not only to be overwhelmed and having confusion, but also wearing them down. There's too much going on. So they're going to be tired. They're going to, the same task that you're expecting them to do is not going to be the same outcome. The solutions provide plenty of rest. This is when they actually take long naps, and that's okay. Shorten activities in the hospital, and you want to share that, especially if occupational or physical therapies are working with them, letting them know that they may not be able to do this whole 45 minutes, 20 minutes or 25 minutes at a time. And then allowing that person to have the best time of the day. When would be the best time of the day for them to actually do those tasks? Problems would change. Loss of ability to plan and sequence of activities. And the world becomes less familiar to that individual. Remember the different settings that I just mentioned, 5, 6 settings that this person has changed within the time span they've been in the hospital. Solution, be consistent, having the same staff as much as possible, routine activities, and maintaining the same environment, even if you have to change the environment in that particular person's room where it's very similar to the environment that the individual has had at home. Too much demand. And too much demand, you may see with individual problems, information can be overwhelming. Unrealistic expectations. And this, again, you see this in the hospital a lot. So solutions, announce only when and what is necessary at that time. Create positive moments. And the best way to do that is when they do something in the hospital, or if certain things occur in the hospital, or if the therapist comes in, or if the physician comes in, or certain areas, you want to be able to say, good job, or even when they have certain tasks that they need to do, good job. Overwhelming and misleading stimuli, the problem is the brain's ability to interpret information has become damaged, and we've noticed that earlier. So the solutions to that is never argue or orientate to reality, remove distractions, what's causing this person to behave this way, and consider what will work for them. That's extremely important. Now, and I believe I'm on my last slide. So communication, when it comes to communication, remember this happens in the beginning. Ability to express and understand has changed. So your solution, respond to their emotions, not what they say. Watch for nonverbal cues. So that sad look or that angry look could be from an individual that they don't like, not necessarily due to pain. Agree, apologize, and distract. And the most important area is therapeutic fibbing. This is what I talk about a lot. With therapeutic fibbing, we want to make sure that we're not lying. I hate to say this. Most people say, I don't really like lying to the individual. But if that's going to change their behavior by sharing with them, if they say, I want to go home, your response may be, yes, we're working on it. We're working on it. Let me find out what's going on, and then we'll work on the opportunity for you to go home, as opposed to, no, this is not your discharge day and you're not going home. They don't understand that. And then the last is activities. This is when they may have problems, the lack of initiative, decreased ability to engage, and they lost a purpose. They don't really know why they're doing certain things. So here, your solution is pull it all together. Manage their fatigue, allowing them to get rest, but when they're not resting, what can we do at that time? Incorporate routine activities. Focus on making them happy, pleasure. If it's food that's going to make them happy after an activity, then reward them with the food. Look towards previous activities and routines they've done. And when I say previous activities and routines, keep in mind the previous activities and routines may not be something they are doing now. It could be something they've done years ago, 20, 30 years, and they will tell you based on their behavior and their interaction with you before they have gone to the hospital. And some of the resources as provided, AFA's National Toll-Free Number, Dementia Care Professionals of America, the AFA's Educational American Tour, Excellence in Care Dementia Care Program of Distinction, National Memory Screening Program, Care Connection monthly webinars, as today, as noted today, Alzheimer's Today with AFA's free quarterly magazine and AFA's Education and Resource Center in New York City. So I hope to provide additional information as it will allow you to actually have, as we call a hospital stay, better hospital stays with your loved one.
Well, thank you so much, Dr. Allen. We now will have time for a couple of questions. The first question that we have is, can you have a combination of the dementias?
Absolutely. You can have a combination of dementia. We've had persons with Alzheimer's disease and, of course, Parkinson's. We've had people who had frontal temporal dementia with Alzheimer's disease. So yes, you can have a combination of various, but this is often picked up by a neurologist because they will determine the person's MRI, their scan or either their behavior. And so we looked at the characteristics of those individuals. So yes.
Thank you. We have another question. I'm wondering about a person who is in subacute care nursing home for rehabilitation after a broken bone and doesn't have an official diagnosis of dementia, but clearly has been going through mild to moderate stages for some time. What can we do for her?
So a person who is in a subacute, and we see this all the time, the first and foremost is we want to make sure that it's greater than a month, because usually we look at dementia and delirium the same, and delirium usually lasts less than a month. If an individual has actually had these signs, basically the characteristics that's mentioned earlier, we want to let the provider know. And we want to actually ask the provider to allow this individual to be tested. Testing can occur by obviously ruling out any type of infections, whether they have a low B12, thyroid levels, urinary tract infection, etc., and then allowing them to what we call take an assessment. And that assessment is usually done by instruments like the MMSE, the MOCA. We also do the MiniCog, SAGE. There are various assessments that you can actually ask your facility what assessment is used. Usually the psychologist would do that, and usually they have a psychologist on board for most of those facilities.
Thank you. We have a question more so for clarification purposes. Just wanting to clarify, because you mentioned that current drugs do slow down the progression of the disease. I believe current understanding in the literature of the medications is they do not slow down disease progression, only aid in symptoms for a period of time. Can you clarify that for me?
Yes, and thank you. And so the medications actually, at the time the individual, they may be in a mild stage. So at that time, they will remain in the mild stage for a longer period of time. So I'm not clear on what the individual is saying, but it has been tested, and of course through trials, that the person who has some form of dementia may stay in that stage a little bit longer and not move towards the next stage. Their behaviors will exhibit that because they're still obviously able to understand and of course remember certain areas. And as opposed to an individual who chooses not to take any pharmacological approach, particularly in those 5 medications I've shared, their progression may actually increase. And it is their behavior as well as their cognitive ability to understand. So that is those medications, is the rationale behind them.
Thank you. We have another question. Can you go into brief detail about the impact of hospital delirium and how we could help the person living with this disease?
Yes, usually delirium occurs when a person prior to hospitalization have not had any cognitive issues or mild cognitive impairment, if you will. And oftentimes due to an infection, certain type of medications, and sometimes those medications can be narcotics or some type of anesthesia. Based on the patient's age, as you know, when a person gets older, their brain is already obviously gotten smaller, so there's inability to think or do certain things because of their age. When you add medication, certain medications, as well as infections, and usually we call UTI is the number one, you begin to see this person exhibit very similar signs and symptoms of dementia. So the person begins to decline. What we want to do, first of all, is address the concern. If it's an infection, how do we address this infection with certain type of antibiotics? Or remove certain medications that's causing this individual to behave in a certain way. Then we want to continue to reorientate them. And you can't do that in one day, what's my name, where are you, etc. It has to occur gradually. For instance, if a loved one is visiting that person and they have delirium, they don't always have to say, I'm your wife. You could just sit there, smile, perhaps bring a picture in that is of you all currently. And of course, a husband and wife's picture, let's say a couple's picture, and just reorient them and say, do you know who this person is? And that's going to happen over a period of days. That person's then going to gradually, as we call, get out of this fog and begin to be reoriented. And you'll see the reorientation usually in 2 to 3 weeks, as long as it has actually occurred, will be the ability for them to get out of it. So in a total of 6 weeks, hopefully there's some progression of cognitive ability throughout that time.
Thank you. We have a couple more moments for some more questions. We have one that just popped up. What is the recommendation for a patient who's brought in due to behaviors that don't necessarily require a medical intervention? Many times after assessment, the ER doesn't see anything they can treat, and it's a family member who is stressed from a new behavior they can't control. What recommendation do you have for preventing unnecessary ER visits?
Well, first and foremost, the family member, the primary caregiver, that person who's been with that person for a certain period of time, that the recommendation is for that individual to be educated on the disease. First, he's saying that this is what's going on with this individual. This is this individual. When I say educated on the disease, it's particularly what I shared with you guys earlier. This is, my loved one has frontal temporal dementia, or my loved one has Alzheimer's disease. That's 1. 2, my loved one is in the middle stage, and I know the signs and symptoms of what the middle stage is. 3, I know what triggers this person's behavior. So if I know this, then I will try to avoid it. 4, I know what to do at the time this person behaves in a certain way, and I know how to de-escalate this individual. And oftentimes, which we have a presentation called Communication and Behaviors, I go into detail about what you do when a certain thing occurs. And in that particular case, let's say a person is escalating their behavior and they're at home, and the person who, the loved one, is unable to really share or control that person's environment. The first thing I share with that loved one, the caregiver, is allow the individual to do what they need to do. Find out what it is that they need to do. If they're trying to go back home, here's what therapeutic fibbing is. Or if they're trying to get out of here because they have to go to work, therapeutic fibbing would be, you know what, you are right, you do need to go to work. Let me pick up the phone, I'll call your job to see if you are scheduled to go to work. So you want to pretty much go into their world. We call it joining the journey. When you're unable to join the journey, this is when you are removing yourself from their environment, allowing them to fight the battle themselves, and bringing another individual or group of people in to care for that person. But they're not going to care for them. They're going to remove them from an environment they're comfortable in and put them in environments such as emergency room they're uncomfortable in, and escalate the issue. And the only result most of the time is medication. So you have control of the environment they're in, and that's probably the most important thing, is the education, identifying what it is, because I've shared with you the diagnosis and the stage, and being educated on what it is you need to know as it relates to caring for that individual during that stage.
Thank you. We have another question. Stages are not always clear-cut. My mother with vascular dementia often expresses symptoms between middle and late stage. So I think she was referring to that, with the different stages, things are not always boxed in. More of a statement, if anything. Thank you for sharing that.
Yes.
We do
yes.
have.
And she's right.
Uh-huh.
No, I was going to say she's right. It's when you meet one person with Alzheimer's disease, you meet that person. So they're not going to be specifically in those stages. Sometimes they go back and forth in the stage. Sometimes some of those characteristics are overlapping in another stage. So she's correct.
Thank you. Um, so we are approaching the 2 o'clock hour. At this time, we don't have any further questions. Actually, we do. Can we take, actually, these are all thank yous. So you are getting a lot of praise. You did a lot of the listeners found this valuable today. I truly learned new information, and I'm really happy that all of you joined to learn something or get a refresher on what you might already know. And I can't thank you enough, Dr. Allen, for volunteering your time and expertise and answering these questions. I hope that we can continue working together, and I really want to welcome everyone back to next month's Care Connection webinar. I hope everyone has a good rest of the day. And again, Dr. Allen, I cannot thank you enough.
Thank you very much.
I hope you have a good day and a good weekend, everybody. Bye-bye.